Welcome to the Deep Dive, where we cut through the noise to get you truly well-informed, one fascinating topic at a time. Today we're tackling a challenge that's probably, well, more common than you think. Imagine this. A brand new healthcare policy is rolled out. It's designed with, the best intentions, meant to improve patient care, maybe streamline a process, but then it just doesn't quite stick. It meets unexpected resistance, or perhaps it just sort of fizzles out without really achieving its goals. Why does this happen? It's a persistent puzzle, really, in the real world.
It absolutely is.
Yeah.
And it's often frustrating for everyone involved, policymakers, clinicians, patients.
Exactly. So today we're taking a deep dive into an innovative research approach specifically designed to crack these kinds of real-world policy puzzles, especially in the incredibly complex world of healthcare.
That's right.
Our mission today is to unpack a powerful, yet maybe often underutilized tool called Q methodology. It's this fascinating blend of qualitative and quantitative research that helps us truly understand how different people think about a topic and what happens when those diverse views clash or align with new policies.
It's about understanding the landscape of perspectives.
So by the end of this deep dive, you'll discover how this unique method helps policymakers anticipate responses, identify crucial barriers and levers, and ultimately create more effective policies.
All by truly understanding the diverse viewpoints of the stakeholders involved.
We'll explore its mechanics, see it in action with some compelling case studies, and consider its broader implications. Let's get to it.
Bro, do it.
Okay, so when it comes to healthcare policy, we often face these massive challenges right from the initial development
Definitely.
through implementation and all the way to evaluation.
It's a minefield sometimes. Prioritizing clinical topics is incredibly difficult when you're dealing with so many competing interests.
And it feels like, more often than not, the biggest stumbling blocks aren't even a lack of resources, but rather the attitudes and behaviors of the key stakeholders.
Exactly. Both those who are responsible for delivering the policy, the clinicians, the managers,
Right.
and the people it's actually meant to serve, the patients, the public.
This is precisely where Q methodology steps in, isn't it?
It is. It's a research method that uniquely combines the strengths of both qualitative and quantitative research.
Right.
Its core purpose isn't just to list what people think, but to systematically explore and describe the full range of viewpoints on a specific topic.
The full range.
Yeah, and what's truly insightful here is that it goes beyond that, to help us understand how people structure their thinking about an issue and, critically, why they hold those particular views.
How and why? Okay.
It really illuminates both the divergent, the disagreements, and the convergence, the areas of consensus among these viewpoints.
That sounds incredibly valuable. So for our listener who might be familiar with traditional surveys or, say, focus groups, what makes Q methodology's process itself so unique? Where do you even start?
That's a great question, because the foundation is crucial. Researchers start by developing what's called a Q set.
A Q set.
Think of this as a carefully curated collection of statements, usually between 40 to 80, that broadly represent the spectrum of opinions on the topic being studied.
Okay, so where do these statements come from?
They aren't just pulled out of thin air. They're meticulously gathered from existing research literature, policy documents, and often supplemented with in-depth interviews or focus groups first.
To make sure you capture everything.
Exactly, to ensure a comprehensive range of opinions is covered. For example, in a study about depression and chronic physical illness, statements might include things like, symptoms of my physical health problem can overwhelm me into depression, or maybe treating my physical health problems will help my depression.
So really getting at different facets of the issue.
Precisely. The goal is to capture all the different perspectives, even the subtle nuances.
And who participates in a study like this? I imagine it's not like a huge random survey trying to hit a massive sample size, right?
You're absolutely right. Unlike traditional surveys that might aim for a massive, statistically representative sample, Q methodology uses what we call strategic sampling.
Strategic sampling.
Yeah, a smaller number of participants, typically between, say, 40 and 60. These individuals are chosen specifically because they have a direct interest or known views on the topic.
So people who are really involved or affected.
Exactly. This could include patients, healthcare workers, administrative staff, managers, commissioners, anyone whose perspective is relevant to the policy.
Okay.
The goal isn't to count how many people hold each view, but to ensure all potential viewpoints are actually represented and thoroughly explored.
Right. It's about the diversity of views, not the popularity.
That's a good way to put it.
So you have your carefully selected statements, the Q set, and you have your strategically chosen participants. What happens next? What's this core activity, the Q sort, that makes it so distinctive?
Ah, yes, the Q sort. This is where the magic really happens, I think. Participants are given the Q set statements, often printed on individual cards.
Physical cards. Interesting.
Sometimes physical, sometimes digital now. But their task is to rank these statements in comparison to all the other statements, typically on a scale like strongly disagree to strongly agree.
Okay, ranking them.
But here's the key. They're asked to arrange them into a quasi-normal or bell-shaped distribution, usually on a grid.
A bell shape.
Yeah.
So they can't just agree strongly with everything.
Exactly. It forces them to make choices and prioritize their opinions. They can only place a few statements at the most agree or most disagree ends.
Mm-hmm.
And the majority have to fall somewhere in the middle, the less strongly held views. It's a very different cognitive task than just rating statements individually on, say, a Likert scale.
I can see that. It really makes them weigh things against each other.
It reveals their relative priorities and beliefs about the topic.
That forced distribution sounds like it really makes them think hard. But if it's all about how they rank them, how do you get at the why behind those rankings, the reasoning?
Great point. That's where the post-sort interview comes in, and it's a crucial qualitative component. It adds the richness.
Ah, okay.
After participants have finished sorting their statements, researchers conduct follow-up interviews or sometimes administer questionnaires. The purpose here is to understand the reasoning behind their specific sorting pattern.
So you ask them about the extremes.
Yes, they'll ask why certain statements were placed at the extreme ends, the ones they strongly agreed or disagreed with, but also, importantly, why some were placed in a neutral position. That can be just as revealing.
True, neutrality isn't always indifference.
Exactly. This provides invaluable context and depth to the quantitative ranking, revealing the internal logic, the structure of their viewpoint.
Okay, so you have these incredibly rich, detailed sorts from individuals plus their reasoning. How do you then analyze all this data to reveal those shared viewpoints you mentioned earlier? What's unique about the factor analysis here?
Right. This is where Q methodology truly distinguishes itself from, say, conventional survey research. Instead of traditional factor analysis, which often looks for correlations between traits or responses to individual survey items across people.
Yeah, like grouping questions together.
Q methodology uses factor analysis, specifically by-person factor analysis, to group people together.
Ah, grouping the participants themselves.
Yes. It identifies participants who sorted the statements in statistically similar patterns. These groups represent shared viewpoints or factors. It's looking for people who think alike in their overall structure of beliefs about the topic.
So the output isn't just a bunch of statistics or factor loadings.
No, not at all. The output is much richer. For each factor, each shared viewpoint identified, the software creates a sort of idealized sort, representing the consensus view of that group.
An average pattern for that group.
Essentially, yes. And then the researchers craft a narrative description of each distinct viewpoint. This detailed analysis highlights areas where different groups agree and disagree, painting this really rich picture of the different ways people understand the issue.
It's not just a list of opinions, then.
No, it's a full story of how those opinions are structured and why they matter to that group.
That brings us nicely to why Q methodology really matters, especially in healthcare policy. It sounds like it goes far beyond what traditional methods offer.
It really does.
I mean, surveys are great for telling us how many people believe something, or maybe linking views to specific characteristics, like, nurses think X and doctors think Y.
Right, they give you prevalence.
But they don't usually dig into the why or the underlying structure of those beliefs.
Exactly. And on the flip side, qualitative interviews or focus groups are excellent for providing those rich, nuanced explanations for why a policy might succeed or fail. But when you have a lot of participants, it becomes really difficult to systematically link those rich themes back to specific individual attributes or patterns across the whole group.
So Q methodology bridges that gap.
I think it does, beautifully. Its advantage is that it clarifies how the components of thinking fit together for individuals, creating this detailed map of the diverse landscape of viewpoints that exist on an issue. It shows you the internal logic of different perspectives.
That seems incredibly powerful for policy implementers.
Absolutely. What's truly powerful here is that Q methodology empowers policy implementers to know who they are working with, as some researchers put it.
Okay.
It clarifies how different stakeholders see the problem, revealing where likely barriers and levers for new policies exist. This foresight is invaluable.
So you can anticipate pushback or find potential champions.
Precisely. And it can also be remarkably useful in conflict resolution because it forces you to understand perspective, even when you strongly disagree with.
I can see that, understanding the why, even if you don't agree.
Exactly. We see this being used not just in healthcare, but in other really contentious areas like airport expansion debates,
Yeah.
environmental waste management decisions, even things like large carnivore conservation policies where conflicting views can completely stall progress.
Fascinating. Okay, here's where it gets really interesting for me. Let's look at some specific examples. Can we dig into some case studies in healthcare where Q methodology delivered these kinds of insights?
Yes, definitely. There are some great examples.
Okay, first up, let's explore why a depression screening policy failed in the UK. I remember this. Back in 2006, the UK introduced an incentive for primary care for GPs to screen for depression in patients who already had diabetes or coronary heart disease.
Right. The idea was to tackle comorbid depression proactively. Good intention.
Makes sense on paper. But by 2013, the policy was withdrawn because doubts emerged over its actual benefits. It just wasn't working as intended.
It wasn't delivering the expected outcomes, yeah.
So Q methodology was used here.
Yes. Researchers used it to understand why the policy didn't get the response they hoped for. They developed a Q set of 57 statements about comorbid depression, gathering them from systematic reviews and, importantly, patient interviews.
Okay, getting the patient voice in there.
Crucial. Then, they had 31 patients, people who had symptoms of depression, also lived with diabetes or coronary heart disease, sort these statements.
And what did they find? Was there an aha moment?
There really was. The analysis revealed 5 distinct viewpoints among the patients.
5 different ways of seeing the issue.
Exactly. And a key consensus was revealed by one particular statement. The best thing for my depression is to see a health professional.
Okay. What did they think about that?
This was ranked neutrally, right in the middle of the grid across all 5 viewpoints.
Neutrally, not positively.
No, which suggested this widespread ambivalence, or at least no strong views among patients, about the direct benefit of seeing health professionals for their depression.
Wow, that's fundamental.
It is. And crucially, some of the identified viewpoints revealed that patients saw no link whatsoever between their depression and their other physical health conditions, like diabetes or heart disease.
They didn't connect the two.
For some groups, no. So the truly eye-opening finding was this disconnect. If patients don't perceive a link between their depression and their physical health problems.
So then why would they see the point of being screened for depression in their diabetes checkup?
Precisely. It completely unravels the policy's underlying assumption. It directly explained why the incentive scheme failed. The study clearly suggested the need for a more flexible, personalized approach rather than this one-size-fits-all screening policy.
That's a classic example of a policy design with one assumption that completely misses the target population's reality.
Wow.
It really highlights the importance of understanding the patient perspective deeply.
Absolutely. Okay, what about another really nuanced area, like how informed choice is understood in different cultures within healthcare? That seems ripe for misunderstanding.
It absolutely is, and that's a perfect segue. Our next case study looks at exactly that, reevaluating informed choice in antenatal screening.
Okay.
Antenatal screening policies, certainly in Western contexts, typically assume women should make unbiased, individually informed choices about whether to undergo tests.
Right, the emphasis is on individual autonomy.
Exactly. But the question is informed choice a universally understood concept, or is it interpreted differently across cultures? That's the challenge, particularly for diverse populations.
So what did the Q study do?
A Q methodology study explored perceptions of informed choice, specifically among women from China, Hong Kong, and Pakistan who are accessing care.
Okay, diverse cultural backgrounds.
Yes. And the results were really eye-opening. 5 distinct viewpoints emerged again.
And what did they show?
These viewpoints consistently highlighted that women from these cultures often preferred making decisions with healthcare professionals and/or their partners. There was much less emphasis on individual rights as the sole basis for decision-making compared to typical Western models.
So more relational, less individualistic.
Precisely. It directly challenged the policy's predominantly individualistic approach to informed choice.
That's a critical insight. It really makes you question the standard approach.
It raises an important question. How can policy and practice guidelines be reframed to facilitate decision-making processes using more relational approaches to autonomy?
Right, to actually support how people want to make decisions.
Exactly. This study showed that if the policy doesn't align with how people naturally make decisions, particularly in diverse cultural contexts, it will inevitably fall short. It has direct implications for improving quality of care and equity of access.
Yeah, huge implications. Okay, one more example. Maybe something tackling professional attitudes.
Sure, let's look at addressing gender inequality in medical schools. This is another persistent, difficult problem.
Definitely. Despite numerous initiatives over decades, the number of women in senior academic medicine positions often remains stubbornly low.
It does. So the question is, what kinds of attitudinal barriers exist among academics themselves that might perpetuate this?
Right. What are the underlying beliefs?
A UK medical school study used Q methodology to identify academics' viewpoints on addressing gender inequality and these potential attitudinal barriers. Participants ranked statements about different interventions designed to promote equality.
And what emerged? Did they all agree on the problem or the solutions?
Far from it. They found 6 distinct viewpoints, and these showed strong divergence, particularly on the strategy.
How so?
Specifically, there was a big split on whether just following good practice, essentially, existing guidelines, and hoping for the best was sufficient, or whether more proactive, positive action, things closer to affirmative action, was the most appropriate strategy to actually achieve gender equality.
Ah, so a fundamental disagreement on how to fix it.
Exactly. The core insight wasn't just that inequality existed, but that there was this fundamental disagreement on the approach.
So how does knowing that help?
By identifying these deep-seated areas of both agreement and discord, the study provided invaluable insights for decision makers, for the leadership. It's particularly useful when potentially contentious action might be needed to overcome these deeply ingrained attitudinal barriers.
It helps you see where you might face resistance and maybe where you could find allies or build consensus.
Precisely. It maps the political landscape within the institution, in a sense.
Okay, connecting this to the bigger picture then. These examples show Q methodology is great for understanding specific policy problems, but what about broader applications, like solving priority conflicts?
Yes, that's a major area where it shines. In a world of finite resources and competing demands, especially in healthcare, policymakers constantly face really difficult trade-offs.
Setting priorities is tough.
Incredibly tough. Q methodology can help clarify healthcare priorities by reducing this multitude of complex, often conflicting opinions into a manageable number of shared viewpoints. It clearly reveals where there's consensus and where there's disagreement.
Can you give an example?
Sure. There was a U.S. hospital that used it in its strategic planning process. They found a surprising consensus on certain priority objectives,
Okay.
which actually gave them the justification to stop doing several existing programs that weren't aligning with those shared priorities.
Wow, so it can support decommissioning too.
Yes. And similarly, in the Netherlands, Q methodology helped find consensus in obesity policymaking, even though there were competing views initially, by identifying shared ground and proposing alternative ways forward, like using different kinds of health facilitators.
That's powerful. And it also seems to have a significant role in improving policy implementation and uptake based on the examples.
Absolutely. By understanding the different viewpoints beforehand, the method can lead to concrete suggestions on how to adapt policies in practice.
Tailoring the approach.
Exactly. This is especially crucial for improving uptake in harder-to-reach groups whose perspectives might otherwise be marginalized or completely missed in the initial design phase.
So it helps avoid those failures, like the depression screening example.
Hopefully, yes. It allows for what some call a reflexive appraisal of policy initiatives, a chance to step back and see it from multiple angles. It helps identify stakeholders who might be overlooked.
And I think you mentioned earlier, it could even forecast engagement.
Yes, what's also incredibly useful is its ability to simultaneously study both objective issues, like resource availability, and subjective issues, like attitudes and beliefs.
Okay.
This combination can help determine an individual's overall opinion structure and actually forecast their likelihood to engage positively or negatively with a new policy, say, in a healthcare workplace.
Imagine knowing in advance who is likely to champion a new initiative and who might resist it, and more importantly, why.
It gives implementers a significant strategic advantage.
Now, like any powerful tool, Q methodology must have its challenges and limitations. It can't do everything right.
Absolutely. It's important to be clear about what it doesn't do.
Okay, what are the main limitations?
While it excels at identifying the range and structure of views, Q methodology isn't designed to tell you the prevalence of those viewpoints in a larger population.
So it tells you what the main viewpoints are, but not necessarily how many people hold each view across the country, for instance.
Exactly. And it also doesn't usually aim to associate those viewpoints strongly with specific sociodemographic characteristics like age or gender, though you can sometimes see patterns. Its focus is the viewpoint itself.
That's an important distinction. But are there ways to bridge that gap? If you know the viewpoints, can you find out how common they are?
Yes, there are ways. We can use a complementary method called Q blocks.
Q blocks.
Yeah, this involves taking the distinct viewpoints identified by Q methodology, those rich narrative descriptions, and turning them into concise synopses or summaries.
Okay, like a paragraph describing each view.
Pretty much. These Q blocks can then be incorporated into larger questionnaires for traditional surveys. Respondents read the blocks and indicate which one best represents their own view.
Ah, so you use the qualitative depth to create categories for a quantitative survey?
Exactly. It allows researchers to estimate the prevalence of each viewpoint within a much broader sample. It's a neat way to get the best of both worlds, the depth of Q and the breadth of surveys.
That makes sense. Is there anything else researchers or policymakers should keep in mind?
Well, there's an ongoing challenge, I'd say. While Q methodology offers these incredible insights, there's still relatively limited published evidence on how these detailed outputs have actually been used effectively to plan or implement policy changes in practice.
So the link to real-world action isn't always clear.
It's not always well documented or easy to achieve. Researchers need to get better at translating and presenting these complex findings, the narratives, the sort patterns to busy policymakers in ways that are accessible and actionable.
Making the insights land, basically.
Yes, the information is often there, but bridging that gap to tangible policy change remains a hurdle sometimes.
And one final point on limitations.
Yes, a crucial caveat to remember. Even if a particular viewpoint identified by Q methodology is relatively uncommon in the study sample,
Okay.
it should not automatically be dismissed or excluded from policy decisions.
Why not?
Because if that viewpoint, even if held by a small number, has the potential for a large impact on policy uptake, especially if it's held by an influential group, perhaps senior clinicians or managers,
People who can block or enable things.
then its significance demands attention regardless of its statistical prevalence.
Yeah.
It's about the potential impact, not just the numbers holding the view.
That's a very important practical point.
Okay.
And that brings us towards the close of our deep dive today. We've explored Q methodology, this really powerful tool that goes beyond simply asking, what do you think? To truly uncover how do you think, and crucially, why.
Getting at that structure of subjectivity.
Yeah. It seems like it's transforming how we can approach the complex world of healthcare policy, from understanding why well-intentioned initiatives sometimes, well, fall flat, to building consensus on really contentious issues where viewpoints might seem completely polarized at first glance.
It offers a path through that complexity.
So next time you hear about a new policy, whether it's in healthcare or any other domain, I really invite you to consider the myriad of viewpoints that might exist. Think about the people it's meant to serve or the people who have to implement it on the ground.
Yeah.
How might deeply understanding those different perspectives lead to not just good policy, but truly great and effective policy?
It shifts the focus from just the what of the policy to the who and the how.
Ultimately, it feels like Q methodology reveals that effective policy isn't always about imposing a single top-down vision.
No.
But maybe more about artfully mapping and navigating the why behind diverse human beliefs and values, turning potential resistance into a blueprint for success almost.
Well said. It's about working with that diversity of perspectives.
So, a final thought for you to ponder. What important policy issues in your own life, your community, or your work might benefit from such a deep understanding of varied perspectives? Something to think about.
Thanks for diving deep with us today.
My pleasure.
We'll catch you next time on The Deep Dive.